Dear colleagues, dear friends, my name is Cedric Hermans, and it's a great pleasure to welcome you to this new podcast, which is part of the EAHAD E-Learning program. Today, we will discuss about inhibitors and immune tolerance induction in the era of Emicizumab. And it's my great pleasure to welcome today Professor Carmen Escuriola-Ettingshausen. Carmen, welcome.
Hello, Cedric.
So, Carmen, it's nice that you can join us today. So I know that you are really passionate about inhibitors. You have been working in this field for many years. Is that not the case?
This is really true. So I'm in this field since 30 years now, and particularly in the field of performing ITI in patients.
Yes, this is certainly your expertise. So we all know that we now have new treatment options. The treatment landscape is totally different. So should we still be concerned about the risk of inhibitor development in our patients with hemophilia?
Yes, I think so. So nevertheless, our current treatment strategies include the application of bypassing agents in case of bleed, surgery, and of course we can perform prophylaxis with Emicizumab, which has been licensed a few years ago, particularly in inhibitor patients. And nevertheless, with the prophylactic administration of Emicizumab, we are not able to make patients tolerant towards factor VIII again. So ITI still plays an important role when we are treating patients with factor VIII inhibitors.
Yeah, because this is true. Emicizumab, Hemlibra mimics factor VIII, but this is not factor VIII. So that means that you will never develop tolerance to factor VIII if you are treated with Emicizumab. Am I correct?
Exactly. On the one hand, we can achieve excellent results concerning the prophylactic use, concerning the prevention of bleeds, but we will never achieve tolerance in those patients because we do not administer factor VIII antigen.
Yeah, before we go on and discuss what we should do in 2023, could you remind us what are the current strategies to treat patients with inhibitors?
Well, once a patient develops an inhibitor, in low titer inhibitors, we are still able, and in this I would like to refer to factor VIII inhibitors, we are still able to administer higher doses of factor VIII in case of bleeds or to cover surgery. Nevertheless, when it comes to the high titer inhibitor patients, we have to use bypassing agents for bleeds, surgery. We can use these agents also for prophylaxis, but this is quite cumbersome. This is not as effective. And we have, since 2018, the possibility to use Emicizumab for prophylaxis. But current treatment strategies also include immune tolerance induction therapy.
The goal of immunotolerance is really to try to eradicate the inhibitor.
Exactly.
What are the current protocols or the protocols that you would recommend to our colleagues?
The current protocols differ a lot between the protocols we are used since decades, because the traditional protocols, the bond protocols, the high dose protocol, intermediate dose protocol, low dose protocol, they all include the regular administration of factor VIII. More, it includes the frequent high dose administration of factor VIII, particularly to achieve success, but also to prevent patients from breakthrough bleeds. If this with factor VIII could not fully achieved, we were using traditionally bypassing agents as Novo7 or Fiber, but with the introduction of Emicizumab, this changed a lot. So current ITI protocols usually tend to include Emicizumab prophylaxis plus less frequent factor VIII administrations. I still do not want to focus on the dose yet.
And regarding all these protocols that have been extensively studied, so could you summarize quickly what have been, the most frequent outcomes with these protocols?
Yes. So success was achieved in 60 to 80% of these patients with a vast majority of these protocols. The biggest differences between, let's compare here, the high dose and the low dose protocol could be shown in the international ITI study. So both protocols, and here we refer to patients with a good prognosis for ITI, let's focus on a maximum inhibitor titer of 200 Bethesda units. They had a comparable success, but with a low-dose protocol, the patients bled more often. So what does this success mean? We make patients tolerant to factor VIII, and we can treat those patients with factor VIII in normal clinical settings.
And in terms of a definition of success, so what would be, rigorously speaking, the definition of success when you are treated with ITI?
So, of course, a negative inhibitor titer. And then we have these scientific definitions as normal recovery, above 66% of normal, a normal half-life, above 6 hours. But I think from the clinical perspective, this means that we should be able to use factor VIII in standard settings, such as prophylaxis, such as surgeries, treatment of bleeds, in standard doses and standard intervals. And this, of course, requires a normal factor VIII PK profile of the patient.
So over the last 2 decades, there have been many initiatives to really motivate doctors, the entire community, that to perform ITI, because this was really the ideal option to get rid of the inhibitor. But now we have emicizumab. And emicizumab has been widely and is widely and largely used in many inhibitor-positive patients. And some doctors and some patients and some families question the fact, should I still, undergo ITI, which is still a burden when I'm on EMI. So what would be your advice to our colleagues about this?
Yeah, you are absolutely right. In the era before emicizumab, we did our very best to give the patient a chance to get factor VIII prophylaxis again. This is not necessary at this moment now, but we have other strong arguments to perform ITI nowadays, which is the possibility to control, to treat bleeds with factor VIII, to cover surgery, particularly major surgery with factor VIII. Monitoring might be an issue in patients being treated with emicizumab. We know that we can't use the standard assays, such as the one-stage assay. We need certain assays, the bovine chromogenic assay. We also have some safety issues. We still do not know whether emicizumab is let's say, the most adequate treatment in every single patient. And we hear about complications with this still rather new treatment. And if we look into the future, or nowadays we have gene therapy available. At the moment, gene therapy is only available for patients with a negative inhibitor. And therefore, I think we should really do our best to keep a patient inhibitor-free, because the patients are on the safe side, but we, the doctors, we feel more comfortable to treat a patient without an inhibitor.
Okay, so you summarize the many reasons that should still motivate us to embark on an ITI, even if EMI is around and the patient is doing well on EMI. But now the next question is, how should we manage ITI, and what protocols are currently available or being tested to achieve this ITI in patients on EMI? Could you share the information that is currently available on this?
Yes, I think we can really use less burdensome factor VIII-based ITI protocols combined with an effective, reliable prophylaxis with emicizumab. What does less burdensome mean? Well, I think the most important step is that we are lowering the frequency of administration, which includes usually the administration 3 times weekly, or factor VIII, and the dose. There is still a debate whether the dose plays a role. So we have low dose protocol means 50 units per kilogram body weight given 3 times weekly, up to an intermediate to high dose protocol, 100 units per kilogram body weight given 3 times weekly. This is, by the way, the Atlanta protocol, and this is the only protocol where we have most experience, but we can also escalate up to a high dose protocol, up to 200 units per kg per day.
And although this could be a little bit speculative, but any suggestion about the type of factor VIII that should be used when, starting ITI in an EMI patient? Any suggestion, or is it too premature?
I think this is really too premature. We had a heavy debate before the introduction of emicizumab already, and we have not a single prospective study showing us the advantage of the one or the other, means recombinant standard half-life, plasma-derived von Willebrand containing, and very recently the extended half-life products also published some experience, but I think it's too prematurely to give any advice here.
And I think we have to recognize that EMI provides an excellent bypassing agent to perform ITI with high probability or nearly certainty to prevent all the bleeds, something which is difficult sometimes to achieve with other bypassing agents such as FIBA or Novo7. So in my view, that certainly facilitates ITI in these patients. This is also your experience.
Exactly, and I think also with the prevention of bleeds, we can also speculate a less immunological trigger, because particularly huge bleeds might trigger the immune system and might interfere with ITI causes. This is something I observed in the one or the other patient, and this can be, let's say, almost completely prevented with emicizumab prophylaxis during ITI.
So it's not impossible that the success of ITI could even be higher than previously documented using EMI plus factor VIII. This is not unlikely.
No, it's not unlikely, but we have to investigate this. I think it's still too early to state this.
And so let's be optimistic. You already shared this data. It's very likely that the patients will achieve tolerance. So the patients will then be treated with EMI in the long term. But do you feel, or is there any evidence suggesting that these patients should still be exposed to factor VIII to remain tolerant or not lose their tolerance over time? Any data supporting this at this stage?
Very difficult. So at the moment, all data support to continue with factor VIII, because this is exactly what we did in the past. Once a patient achieved tolerance, of course, we continued with factor VIII prophylaxis. And this is, by the way, the recommendation of the UK guidelines. Even when achieving tolerance together with emicizumab prophylaxis, they suggest to continue with a factor VIII prophylaxis. But Cedric, you just mentioned it. It's very unlikely that parents agree to do so. So it's very likely that they want to continue with emicizumab standalone therapy. Potentially that it might be possible, or it might be recommendable to wean factor VIII very slowly. Some colleagues even discuss to administer low doses at low intervals continuously, or to stop immediately. We still do not know what to do. There is one study investigating this. This is stopping factor VIII or continuation of factor VIII together with EMI, and this is the so-called priority study.
Yeah, which is run by one of our American colleagues. And a last scenario is that, let's say the patient has an inhibitor, is on EMI, does not have ITI. So what could, because I think this is also an important concept, so what could happen to that inhibitor over time if the patient does not receive any factor VIII for months or even years? What could happen to that inhibitor?
So what we observed and what also has been published is that the inhibitor titer decreases in numerous patients. It even becomes negative. Nevertheless, this phenomenon is not observed in all patients. What we usually observe once we re-expose the patient with factor VIII, we see a classical anamnestic response, means that the inhibitor rises again after factor VIII exposure.
But that would, if I'm correct, that would still allow to perform an invasive procedure with factor VIII, considering that the inhibitor will very likely come back very soon.
Well, I think this depends on the immunological response of the patient. So I observed patients who had an anamnestic response after 2 weeks, and I saw others after 2 days. So thinking about conducting a major surgery, 2 days is quite short.
Well, I think, we covered most of most of the topics in depth, and I think it was a very great discussion about this new treatment landscape and how HEMI is changing the way ITI should be perceived and the modality. So Carmen, it was a great pleasure. So I'd like to thank you again and invite all our colleagues to watch the entire video, which is on the EAHAD E-Learning platform. So Carmen, thank you, and I hope to see you soon.
Thank you, Cedric. Hope to see you soon.